there was another study that was done a little later that looked primarily at safety. This was the third pivotal study that was used for submission to the FDA for approval of the medication. And that study was very large. It had about 1,340 patients, again, patients with refractory epilepsy, so 20 years plus duration of epilepsy on average, with mainly 2 to 3 medications on board. And the primary focus of that study was safety. And the results there were favorable. There was a subgroup of those patients at centers that had a relatively large number of patients in the US, a large number of patients being 10 patients or more, and who kept track of the efficacy of seizure frequency. And there was a sub-analysis of those patients. There was a total of 240 out of those 1,340 patients in those 10 centers that were very active and kept seizure frequency count. And that study showed very similar efficacy result in this patient population. And that study was even more approximate to the real clinic experience, because it was open label. You could enroll patients from the clinic, and you then treated them, you adjusted the dose to efficacy or side effects. And the efficacy results were very similar to the open label extension that I just told you. The side effects were very similar also. And then, as you indicated, there was a bunch of sub-analyses from that study. They included looking at whether you had better response when cenobamate was combined with one medication or 2 medications versus 1 or 2 others. Most patients had 2 to 3 medications as background. And in that study, cenobamate could not be used as monotherapy. So if you reduce medications, you had to stay on at least one other medication. And bottom line is that there really wasn't a pattern of better or worse efficacy with cenobamate depending on the other medications, meaning that it is not a particular combination that gives you this remarkable efficacy, but that it is cenobamate. There was several other studies. One of them looked at the very most severe patients, those patients who undergone surgery, either resective surgery or RNS implantation or venous implantation or 2 or 3 of those. And the efficacy there was, again, very similar to what we've just discussed in these most refractory of epilepsy patients. So, and I have had those patients in my cohorts, patients who failed 15 medications and surgery, and lo and behold, they're now seizure-free. So that was another analysis that was quite remarkable. A third analysis looked at the impact of cenobamate on dosing or continuation of other medications. And there was a high proportion in that safety study, and there's a high proportion of patients, roughly 25%, who stopped one other medication. And there was a high proportion of patients who lowered dose of 1 or more medications. So that tells you that if you've got other medications on board as background medications, and you do achieve response with cenobamate, you can discontinue or reduce the dose of other medications. So you can reduce the overall medication burden. And again, cenobamate has now been on the market for 2 years. We've had a long experience with it, and I can sort of corroborate it from my clinical practice that I've had that experience that you can reduce the dose of medications and discontinue some medication and often reduce the dose of more than one medication.